All right, good afternoon, everybody. Welcome. I'm Roberta Phillip Robbins. I'll be facilitating today's meeting. We will be recording this meeting for purposes of sharing with folks who can't attend. This is a public meeting. We are having some difficulty with YouTube Live, but the meeting will be accessible after the fact, and the chat is still subject to public record. If you have any connectivity issues or you get kicked out, please contact Brandy Hemsley, and her contact info is always in that invite. Live captioning is available in English and Spanish for today's meeting, and we can drop that link in the chat for you. So heads up to everyone that this is a live meeting, even though we're not technically going live at the moment. So welcome. Good afternoon, Roberta Phillip Robbins, a member of the consulting team working to support the Oregon Health Authority with the implementation of Measure 110. I'll be serving as your facilitator again for today's meeting. So last week, this group heard from the rules coordinator at OHA, and you discussed the potential work of the OAC's Rules Advisory Committee, or the RACs as they call them. You discussed the RAC and the potential for multiple RACs. That conversation will continue in future meetings, so it's not lost in the sauce, just for your tracking. Your tri-chairs have decided, though, to focus the group's energy today on the BURNS, the Behavioral Health Resource Network, and your collective vision for how services should and will be provided. So to start, you'll hear about some workforce issues, and then we'll get into the conversation. Your chairs have decided that Sabrina will lead today's meeting. It was Keisha's turn. Keisha's not able to lead today's meeting, and we look forward to her joining us again in the future. But Sabrina will take over for today's lead, and I'll turn it over to you, Sabrina. Thank you.
Good afternoon, Council. I'm glad to be here today. So on our agenda, we're going to be talking about the behavioral health workforce investments with Mark Overbeck, Director of the Primary Care Office, OHA's Health Policy and Analytical Division. And then we'll talk about the behavioral health workforce crisis with Thomas Bialazar, please forgive me if I slaughtered that name, Director of Behavioral Health, Columbia Pacific CCO. And then we'll delve into some more conversations around the burn vision and the workforce. So right now, I would like to welcome Mark Overbeck, and thank you for being here today.
Sabrina, thank you so very much for that. And also here is Neelam Gupta, the Director of the Clinical Supports Integration and Workforce Unit that my team sits inside of. Are you able to hear me all right? Great. Well, it was nice to see some familiar names and familiar faces as people were logging in today. Neelam and I are here really to respond to your questions and to lay out a very, very high level set of information as far as we are aware right now about, as you spoke about, the behavioral health workforce initiative that has come from the passage of House Bill 2949 in the last legislative session. If we go to the next slide, please.
Mark, before you get too far in, I just let you know that we will monitor the chat for questions for you. And is it okay for folks to interrupt as you go along?
Absolutely, absolutely, absolutely. Thank you, Roberta, for asking. Yeah, I think Wes said that we had about 15 minutes here, give or take, with questions, and feel free to interrupt at any time. And if there are questions at the end, Neelam and I will be happy to answer those as well. And I recognize that for some of you, you may be very familiar with House Bill 2949. For several of you on the Advisory Council may not be. So it's really intended for everyone. Feel free to interrupt and ask questions as we go along. The background on House Bill 2949 is one of several major components on the legislative investment in behavioral health in this last legislative session. This particular bill was originated with the Legislative BIPOC Caucus. Representative Bynum was a very key chief sponsor, but was joined also by Representative Alonzo Leon, Representative Schouten, and Representative Tana Sanchez also had a very important role in this. The bill was introduced in one form and then very quickly incorporated the components of another bill, House Bill 2086, which originally included workforce investments that were proposed by the Governor's Behavioral Health Advisory Council, which Steve and others staffed from OHA, and several of you may have participated with. Thank you. If we go to the next slide. So what House Bill 2949 does in part is it allocates $60 million of federal rescue plan funds dedicated to provider incentives to do several things. One is certainly there's a commitment to diversifying the behavioral health workforce. There's also the understanding that increased access needs to be available for behavioral health services in a culturally responsive way, and that are delivered by professionals from, I'm so sorry, it looks like this got cut off, historically underserved populations. The word populations is missing. The second bullet recognizes that we are not delivering culturally appropriate behavioral health services in the way that we need to, and we'd like to have a workforce that more closely resembles the populations that it's serving. And then third, there is a charge specifically in the bill that these incentives will be used, perhaps more generally, to expand the behavioral health workforce in rural and other underserved areas. Those other underserved areas are not defined in the bill, and it is to OHA to define many of the terms, particularly through the rulemaking process. So that's the $60 million. Additionally, and by the way, that money will go into a sub-account called the Behavioral Health Sub-Account within the Healthcare Provider Incentive Fund that is overseen now by OHA. The other investment that this bill makes is $20 million to expand clinical supervision or supervisory opportunities to enable behavioral health professionals who are, they've done their training and they're working toward those 2,400 hours to move through the system in a much more timely way. And I know that Representative Bynum heard over and over the number of hours was difficult. There was a lack of opportunities for those with the training to receive their clinical supervision, and that needed to be changed. So this bill also allocated $20 million again of federal money to expand opportunities for clinical supervision. Thanks. If you go to the next slide. The bill directs that OHA, in considering these investments in determining the distribution of funds, must coordinate with the Higher Education Coordinating Commission, or the HEC, and then also other OHA and DHS related programs. Specifically calls out the investments of ballot measure 110 and this group. So we've included both the HEC and the Measure 110 Accountability and Coordinating Council in our conversations about who must we coordinate with. Now, who must we coordinate with is not the limit of who OHA will coordinate with in considering the specifics of these investments. Thank you. Next slide. Or is this a good opportunity? I'm seeing a number in the chat. I'm purposely not looking in the chat. Is there anything that should be interrupted?
No, there are no questions, but
okay.
It's a great pause point for you if folks want to jump in.
Sure, Roberta, thanks.
All right, I'm not seeing anything, Mark.
All right, great. Well, we really are at the beginning of a very great adventure. $80 million is a historic investment in the behavioral health workforce by any definition. And OHA is charged with this work. So we are in the beginning of this journey in what we're calling an initiating phase. We're at work with our partners from the Health Systems Division, Steve Margie, also with our partners in the Division of Equity and Inclusion, it's Leanne Johnson and her team, to agree on what's an appropriate collaborative governance structure to make sure that these investments are made where they're needed to be made and done in coordination with the rest of the work from OHA around the behavioral health. We're going to be developing a project plan, and there are a number of positions that are associated with this work that the legislature has committed to. And our intention is to be posting the staff positions relatively soon. So those three represent the first upcoming steps for the development and the rollout of this initiative. You move to the next slide. Thanks. Well, I said earlier that those groups, the HEC and OHA and DHS groups, including this one, are not the limit of who will be spoken with. OHA, the Healthcare Workforce Committee, the Health Policy Board, our team in the Health Policy and Analytics Division really, really committed to a very active and meaningful consumer and community engagement process. We've begun some work over 20 different organizations. We've held some listening engagements to help understand, to achieve equity, what changes do we need to make, what strategies do we need to fund, what strategies do we need to stop funding. We're going to continue to do that. And as we in OHA roll out this work, we intend to piggyback onto those listening sessions to continue and enhance the relationships that we do have. Is this an opportunity for if you have a question?
Hi, Mark. This is Karen Wheeler. Good to see you.
Hi, Karen. It's great to see you.
Were any of those listening sessions or engagement sessions in Eastern Oregon? And then the other question I would have, is there a transcript or a report about those engagement sessions?
Wonderful questions, Karen. Thank you. Let me try to respond to them. And if I forget one, just let me know. First, the cute answer is that none of them were held in Eastern Oregon because they were all on Zoom due to the pandemic. The substantive answer is we looked at both statewide coverage and regional coverage. So several of the groups were, quote, east of the crest of the mountains, and several of the groups were statewide. And they range from, without getting too far into the weeds, they range from primary care practices, behavioral health practices, statewide advocacy organizations in the Portland area, in other places throughout the state. We feel that there's a pretty good coverage, and it's certainly not the limit of the work that we're intending to do. As far as is there a report, we will be presenting a report on the listening, a full report on the listening engagements as part of the development of an overall health equity framework for the Healthcare Workforce Committee and our section of OHA on October the 5th at the Health Policy Board. We are going to hold an educational webinar on August the 17th to talk about the development of that framework, including the listening engagements that we participated in. And I think, Karen, you've got probably access to the OHPB calendars, and that would be a great place, but we won't have a full report probably until October. We've done some work to capture findings, and we can share that with this group certainly between now and October as well.
Mark, before we get to Caroline's question, I'd like to address Dharma's in the chat. Dharma, are you willing to speak on behalf of that?
Yeah, hi, I'm
Hi.
Dharma. I just had a question because I know that in the past with a lot of state projects regarding cultural competence expansions, and importantly so, they focused on racial and ethnic representations and equity. I'm wondering if there's considerations for like queer and trans communities and intersex communities, as well as other communities that are gender and sexual minorities, in regards to these expansions, or are they primarily focused on racial and ethnic and regional diversity?
Thank you so much for that. Absolutely not are they limited to race and ethnicity. In fact, the bill itself calls out LGBTQ plus Q youth in particular as a population that needs access to services and is targeted for this initiative. And absolutely, in terms of the health equity framework, we are considering OHA and the Health Policy Board's broad definition of health equity, which goes beyond race and ethnicity. So thanks for the question, the opportunity to clarify. This is not limited to race and ethnicity only.
Thank you, Mark. Dharma, thanks for that question. Caroline?
Yes, this is Caroline Cruz, Confederate Tribes of Warren Springs, Mark.
Yeah. Good to see you, Caroline.
Yeah, so this is being funded by the Federal Reserve Plan. So
The rescue plan, yep.
yeah, what's the timeline on these dollars and how are we going to sustain these efforts once those dollars run out?
That's a great question. I don't have a good answer. I don't have a great answer. I don't have any answer. In terms of the plan for distribution of these dollars, we're way too far in advance yet to be able to say. That's going to be conversations with, as I said, our partners in the Health Systems Division and with Equity and Inclusion, really likely some very senior leadership calls. It's a very, very important set of work. What I can say, though, also is you pointed to something very important, which is that these rescue plan funds are a one-time investment. And now you've called like, okay, if this money is distributed over 3 or 4 or 5 years, even as we look at pipeline development, great to the next pipeline development and loan repayment or other incentives that are multi-year incentives, what happens after that? So, and then I can see Steve has his hand raised, so he may want to add to respond to Carolyn's question.
Yeah, thanks, Mark. So these funds for the American Rescue Plan actually have a longer life than other grants during the pandemic, which in some cases were 6 months or so. This, I believe, extends into 2024, so gives us a line of sight, through this next biennium and beyond a little bit. I think the other thing I heard from legislators is Mark's right. This is a higher level of investment in workforce than we've seen before. We talked about a workforce surge because we have some catching up to do, especially in the area of diversity. Legislators made it clear that based on the effectiveness of these investments, which should motivate us to really spend these dollars wisely, there'll be an opportunity to come back in future legislative sessions and to build on this with investments that wouldn't have the time restrictions of the federal funds.
Great. And to speak to the rest of the slide offers potential strategies. No full decisions have been made. We've looked at what has seemed to work over the past several years in our experience with a $17 million provider incentive fund, which has included loan repayment and other incentives to behavioral health professionals, largely licensed, but now in the last 6 months, we've gone beyond and supported QMHAs and those QMHPs working toward licensure as well. So these are some potential strategies. They'll be informed for sure for the stakeholder involvement. They'll be executed in strong oversight with the senior leadership of the agency. And if we could move on to the next slide. Yeah, I don't know how we're doing in terms of time, but if there are any further questions for myself or for Neelam, we'd be happy to respond. And hopefully that gives a bit of an overview around the opportunity that we have, that we're really at the beginning of a journey that's in some ways a historic journey, and our commitment to engage in this work within OHA in a collaborative way, in a meaningful way.
Mark, we have a few hands up. Caroline and then Ron. Go ahead, Caroline.
Yeah, I know you're not going to forget, Mark, but just in case, I want to make sure that I state this. We've got to make sure that the Tribal Behavioral Health Strategic Plan is included because there's a strong component in terms of workforce development that fits right in with this bill in terms of the language, and that we need to make sure the Alcohol and Drug Policy Council is involved with their Alcohol and Drug Policy Strategic State Plan too. I'm not saying you're not going to do it. I'm just putting it out there as a reminder.
It is great to get on the record, Caroline. Thank you for that.
Thank you, Caroline. Ron, did you put your hand down?
Well, yes, I did, but I still have a question.
Okay, you go, please.
So there was a couple things. One, I was not confused, but I couldn't really kind of break out the difference between recruitment and retention. So what is the priority?
That's a great question. I don't know that there's a set priority. What we do know from our experience is that offering loan repayment for folks to move to an area can be a very powerful recruitment tool. We also know that offering loan repayment and potentially other subsidies and assistance like childcare or housing supports where that's deemed needed is a very important set of tools for retention. So I don't know that we're certainly not now at the point of saying recruitment is more important than retention. We have some feedback that we've gotten from different programs and systems about the need for retention, but we're maybe you could say agnostic right now about where resources need to be directed.
Okay, my follow-up would have been about where would you be targeting your recruitment efforts? And so you're not there yet.
We're not.
And,
We have a lot of good experience over the last 3 years, but this is a different set of funding. It's a larger set of funding. There's specific issues that are intended to be addressed. So we want to take all that into account. I'm sorry, but ask us in a year, we'll be able to say exactly what we're doing.
And I'm sorry, did Ms. Gupta, did you have a comment?
Yeah, I just wanted to comment that we've also heard a lot about the need to create welcoming clinical practice environments. So that's another area where also considering as a potential strategy to increase retention of providers.
Thank you. Just one follow-up was, I wasn't really clear on where the kind of accountability lands. I heard that, I wasn't clear if it was the Health Policy Board or the Healthcare Workforce Committee. Is that a committee of the Health Policy Board? And if so, how does that, I'm not sure, that was a little foggy.
It's because I didn't make it any clearer than that. But yeah, the Health Policy Board is overall the body accountable for health policy. It's appointed by the governor, and really in terms of policy and approval, ultimate approval of distribution of funds, the buck does stop with them. The Healthcare Workforce Committee is a committee of the board. It's in statute, and the committee is charged with making recommendations to the board. And it has done so for really the last 6 years in terms of distribution of different funding given to the legislature for provider incentives.
Thank you.
Is that helpful?
Yes, thank you so much.
Sure.
Thank you. Before we go to Steve, Henry, would you like to ask your question?
Yeah, I just, the other presenter, I'm forgetting their name.
Ms. Gupta?
Yes, Ms. Gupta spoke about creating welcoming clinical practice environments, and I just was hoping maybe they would be willing to expound on that. Thank you.
Sure. I mean, we've heard, through our existing incentives that, sometimes clinical practice environments, particularly in rural and underserved areas, that new providers coming in experience systemic racism or other bias issues. So, we're contemplating, how we can address that, and would love feedback or ideas or suggestions from any of you who, have them.
Henry, do you have a follow-up?
Yeah, I think that my experience having worked in administrative positions as a clinical supervisor at several agencies, I would say that oftentimes what I've heard from staff, line staff, is that they're feeling like basic stressors of capitalism, overworked and underpaid. Oftentimes that when they do go to attempt to unionize, that they're met with aggressive, counter union measures. So I would say, I don't know how OHA or, we as a committee help that process, but I think that, and I don't know if it's just a cultural thing within the United States that is, where we talk about being anti-union, but, I think staff find that there's this sense of antagonism when it comes to the relationship between labor and administration. Thank you.
Thank you, Henry. Steve?
If I can get unmuted. Yeah, thank you, Mark, for this overview of the legislation. Maybe say a couple things. One is to recognize that as we do our work as a council, we will be generating opportunities and need to fill positions to support the work that we'll be funding. And so we'll be an engine of opportunity for behavioral health workers. And if we don't have the workers, despite getting funds out for services, we won't have people to provide those services. So, workforce is going to be extraordinarily important to this group. Layered onto that is right now here in Oregon, we have, in my view, a workforce crisis. We were challenged with workforce prior to the pandemic. The pandemic has really made it difficult to stay in the field, and not just for behavioral health workers, but across all of healthcare. We have a nursing shortage right now, and it goes deeper than that. And so I think to recognize that we have to be, vigilant and concerned and engaged around workforce issues and both recruitment and retention. And hopefully we can get people who have left the field during the pandemic to come back and do this work. And to the extent that this body can help inform those practices, I think that will really serve us well, which brings me to my third point. I think there's a lot of really good reasons that this group uniquely has information about why our communities of color and tribal representatives aren't getting into behavioral health field or don't stay in the behavioral health field. And in helping to inform the work, I think that this body could bring a lot to these discussions about how to craft policy to attract and keep people from our communities of color and people with lived experience to do this work, being uniquely qualified to do the work and really much needed to do the work. So I'm hoping that we can have an ongoing dialogue to help shape where the policy and spending will come over time. Those are my 3 cents, I guess.
Thank you, Steve. We'll take 2 more questions and then we have to wrap up from Mark. Mark, is that all right timing wise?
Certainly.
Okay, go ahead, Dharma, and then Ron.
I just had a question. I know that you folks talked about some of the loan remission that might be part of that. Is there any funds going towards education for marginalized students to as well? I'm just wondering if that's part of their plans or if it's something that could be advocated for.
A great question. There is a list in the bill of potential incentives that could be included, and scholarships are certainly one of those that likely will be. In the listening engagements we've held, we have heard frequently communities speaking about the real challenge. I mean, loan repayment is nice if you can afford up front the cost of your training. So one theme I think we've heard loudly is paying for those educational costs up front. And that could go all the way from pipeline development of having middle school and high school students become interested, maybe even a very upstream scholarship program, to young adults or potentially dislocated workers to consider professions in the behavioral health field, and understanding that we may need to loan or pay many of those educational costs up front. Otherwise, people have a barrier to going into those programs.
Thank you. Ron?
Yeah, I just wanted to echo kind of what Steve was saying, because that's kind of the backdrop of the conversation that we're having today, is we're in the process of considering, expanding access to care through grants and contracts in the environment of what Steve describes as a workforce crisis. And so we need to know in terms of sequencing our work, how we're going to make these investments while simultaneously building the workforce. And so I just wanted to restate that. The other thing I wanted to ask is more of a question, or the question I have is, how does the OAC interact with these other bodies and at what level? I'm not sure if you're the one that answers that, or Steve, or but relative to these other bodies, HAC, DHS, OHA, HPA, you know, where's the connection to the OAC? How are we hearing these conversations and witnessing the deliberations?
Mark, did you want to take a run at it, or would you like
No,
me to?
absolutely not with OAC. I do have something to say just in follow up about our equity efforts, but please go ahead, Steve.
Yeah, well, Ron, we're building this out, and as I expressed, you know, I have a strong interest in having this particular body and a few others in development help inform this work. So I think we're still building out what the process looks like, but I think there's a key opportunity to leverage the knowledge and wisdom of this group to help inform where we're going, and how that looks exactly has yet to be built. But if members of this group are interested, I would love to see that connection being made.
Thank you, Steve.
Thanks. Perhaps my parting comment to this group is that those of us who have been involved to this point in this work are challenged, humbled, and really excited by the opportunity that this represents. I'm saying nothing that I don't think anyone here already understands. That health equity really is not at all health equality. It's not that we're going to treat everybody in the state exactly the same. It does require the redistribution of resources to ensure that everyone has a genuine opportunity to be healthy and to participate in the system. So that's a little bit of where the challenge and the dauntedness comes from, but it's important work. And thank you for the opportunity to speak with you and hear your questions as we are at the very beginning of it.
Mark, thank you. Thank you, Neelam, for joining us as well. Appreciate you.
Yeah.
Hubert, do you have a question for the group? All right, I will mute Hubert. So I'll turn it back over to Sabrina to run us through the agenda. Thanks.
Okay, thank you. And then now we're going to have our next speaker, Thomas Balzar. I apologize if I'm not saying that correctly. Welcome. Thank you.
Sorry, just working on my camera here to make it work with Zoom. Sort of working. There we go. All right. Can you hear me, everyone?
Yes, we can hear you, and we will monitor the chat for you if questions come up. Can folks interrupt if they need to?
Absolutely.
Okay.
Yeah.
Awesome. Thank you. Welcome.
Yeah, thank you. I want to say thank you to Wes and to Lakeisha for the invite and for the opportunity to be here today. My name is Tom Byloser. I'm the Director of Behavioral Health for Columbia Pacific CCO, which is part of Care Oregon. Care Oregon supports 3 different coordinated care organizations: Jackson Care Connect in Jackson County, Columbia Pacific CCO in Columbia County, Clatsop County, and Tillamook County. And then also we're a part of the Health Share CCO framework in the Portland metro area. And so I really appreciate the opportunity to speak with the council today and run through a little bit of the information that we have on the behavioral health workforce crisis. And as you can see, it's a little bit of background on what it is and how did we get here. And so I just wanted to speak a bit to some of the history and where we think things stand now, and take any questions. So if we could move to the next slide, that would be great. So just, in terms of the evolution, how did we get here? Historically, low rates into the mental health and SUD network and corresponding wages that really we're not necessarily competitive relative to other industries have kind of been an underlying driver, I think, for a long time. Added to that, there's a dynamic where unlicensed clinicians who are either working independently under a plan of supervision, they can bill and work independently. And there's been a rise in the reimbursement for those clinicians, which can be considered a good thing. However, that also draws behavioral health clinicians away from organizational work in behavioral health agencies that are oftentimes delivering core services and higher intensity services. So that kind of fuels a dynamic of a whole bunch of different providers kind of going out on their own, so to speak, and a little bit more fragmentation in the behavioral health system on the whole. So, another factor I think that it's important not to underestimate is what we call COVID burnout. And I heard this from a clinical director in a provider organization that we support just this week that, a lot of times, I think over the last, year and a half, everyone's been trying to hold it together in every way that they can. And that includes behavioral health providers. And I think, as in the phase that we're at in the pandemic, when folks kind of get a minute to think and reflect, I think there's a collective feeling of stress, exhaustion, burnout for folks in the field. And I think that really takes its toll. And there's almost kind of a delayed effect, if you will, about that. Another dynamic relative to the Oregon State Hospital, as we know, the state hospital has been closed for individuals that are in a civil commitment status that potentially can benefit from support from the Oregon State Hospital. The state hospital has really been focused on the population that is termed aid and assist. So it's a context where there's justice system contact and kind of a forensic context versus being open to also this population of civilly committed individuals. So, what that looks like is lengths of stay in hospital settings that can be longer, and just quite frankly, a lot of bottlenecking at different levels of care, whether that's residential treatment facilities or secure residential treatment facilities on the mental health side, or acute inpatient facilities. And so I think part of that challenge is just a lot of demand and a lot of need. And I think the workforce that wants to help and do the right things, they're tapped in and perceiving and feeling that demand and wanting to help, and it can be overwhelming. So I think as we've talked about maybe before, a cycle of burnout. So as clinicians leave, let's say, especially around team-based work, teams that serve children or serve adults, where there's multiple folks on a team, as 2 or 3 people leave, there's just a consolidation of more and more work, more shifts, etc. I heard an example of someone working at a respite center that had worked 40 hours of overtime in 1 week due to staffing. And, it's pretty challenging. And that obviously, when there are shifts to cover and not enough workers to cover them, there's just burnout that happens as part of that. Another factor is there's a burden of administrative work. So reporting, documentation, standards that are held in the way that our behavioral health system is built, with a system called a certificate of approval, which basically supports unlicensed clinicians working within an agency. And then the kind of the trade-off, if you will, is the agency has a number of administrative requirements they have to meet in order to work within that framework. But there's a lot of additional documentation and additional rules that apply. And so, meeting those is time consuming. And as you can imagine, draws down time from focusing on direct care for consumers and individuals. So I think we can move to the next one. So to give you an idea of how things looked before prior to the access crisis, which we think has really intensified, especially in the last 8-9 months. For outpatient services, there was a wait time of generally 2 weeks, maybe some wait times that were beyond for outpatient services, excluding psychiatric services. Intensive services, what's called level D services, which are really in-home services for kids or community-based services for adults, generally had wait times of 2 weeks out or a little bit beyond. There was no wait list for assertive community treatment or intensive case management services in the metro area up through December. And those programs serve, generally speaking, serve our most vulnerable adults in the community, so they're really critical services. Sub-residential and detox programs were operating at full capacity. Children's psychiatric residential treatment services and subacute treatment services were operating at full capacity. Those were kind of the institution-based care services that are one step down from hospital inpatient level care. And then in most years, the turnover of clinical staff averaged approximately 20 to 25% annually, which is not great. I mean, if you think about that, that is a counselor in a sub-program changing over, 1 out of 3 changing over every year. Obviously that's disruptive enough. That turnover rate is now closer to about 45% annually. So nearly half of the workforce turning over within their agency or program in a year. Turnover has been even higher for the community-based programs that do the most intensive work. And then in 2019, 200 civilly committed patients entered the Oregon State Hospital. In 2020, that number was 20 in total. So as you can see, there's a lot, that's changed in that time. I also want to note before we move on, one thing that has happened with COVID, many sub-residential and detox programs had to operate at less capacity due to physical distancing limitations and COVID precautions. So that's one other thing that changed in the last year. If we want to move to the next one, that would be great. So, bringing it closer to home, we always want to take a focus on, as we in the CCO world say, a member or a member of our CCO, and thinking about the impacts to members. So there are caseloads in some instances that range to 90 to 100 members per clinician. If you can just sit with that number for a second, the idea of holding space for everyone's story, everyone's needs, if they've had a history of trauma, if they've had, a different story in terms of what they need for support relative to social determinants of health or housing. That's just a lot, I think, for any person to keep track of. And so I think that dynamic is overwhelming, and it feels overwhelming to a member because it feels like maybe you can't get the amount of appointments that you're hoping for, you can't get the amount of time that you want with whoever you're working with in the behavioral health system, and care may feel less personalized. And so I think that's one of the things that really happens downstream with that dynamic. And deciding between behavioral health work or other work, like an Amazon warehouse, or in some cases, Home Depot in one community, even fast food restaurants have begun offering hiring bonuses and other financial incentives that are competitive from a financial perspective compared to work in behavioral health, which is inherently more stressful and more challenging, and is a different kind of calling. So I think the labor market has been really disrupted with COVID, and things have changed in terms of compensation in different industries. And I think everyone is catching up to that. Looks like we've got a question from Margie.
Yes, thanks, Tom. Margie, go ahead.
Thank you, Roberta and Tom. I want to go back to the next slide, if we could, Thomas, because I think maybe I missed something in what you were trying to. No, the one that had the no. Oh, that is it. Your number 3 bullet there about no wait list for ACT. And what is it you want us to glean from that? Because the first thing that comes to my mind, well, why is it there's no wait list there when everything else is backed up? Are there barriers, or what do you want us to get from that message?
Yeah, wonderful question. So I think in this, we're painting the picture of how things were, rolling back 12 months, 18 months ago, really more 18 months ago. So, for that example, if someone were to go to a higher level of care like the hospital and then need to connect with a community-based team, an intensive team, generally speaking, that team could meet with them the next day or the day after. Now, there's a wait list for those services, especially in the metro area. And so that's really what's happened. That's the current state, is there's a wait list. And I think, I'll just say my worry for that is that if someone needs crisis level care and a community-based team checking in with them, supporting them, and they're waiting for that service, there's just risk in that picture for that individual. And I think that's kind of how it resonates for me. So having wait lists for any of those programs is really not optimal at all.
Thank you.
And the reason for the wait lists is really in that 5th bullet. The turnover for the community-based teams is just really high. Oh, thanks, Ron. ACT stands for Assertive Community Treatment, where there's usually a team that includes peer support, QMHA level case management support, a QMHP level therapist, a higher frequency of psychiatric services, and then also supported employment. So it's a multidisciplinary team approach to intensive services.
Thank you.
Yeah, thank you. And then to the last quote, I think as you can see the quote there, we've had a program say that they've had only 2 unqualified applicants for a position posted since December. So positions that just stay open perpetually is one quote from one provider. And other years, you can see the turnover that we already talked about. And then the last one is turning down new clinical programs or opportunities to stand up new services because the providers don't know where they'll find a workforce. So that's a little bit about the dynamic. And if we could move to the next one. So relative to concerns in Metro, what we're seeing downstream is a limit to the timely access for services for non-hospital discharges. So if someone is discharging from another setting, whether that's residential care or non-hospital setting, they may be waiting for care. And as I said before, that's really not something that we want in our system. Larger caseloads. So clients who need level C or above services, those clinicians may have up to 90 cases. So what level C is basically a community-based or intensive level of services or intensive outpatient services. And there really should be smaller caseloads to correlate with clinicians being able to spend more time meeting with everyone. So that's the concern there. Gaps in care for culturally responsive services. So again, if the culturally specific provider organizations don't have the workforce, it's that same effect of caseloads that are too high and not enough staff to meet with everyone at the level, at the frequency that's needed. Standard outpatient clinics have wait lists of up to 6 months, and some are not even taking a wait list. And obviously that's concerning. EMDR services are, it's the rapid eye movement treatment that is most typically paired with trauma treatment or treatment for PTSD. High acuity clients with, I don't like to say high acuity clients, but clients with greater needs relative to acuity, like I described before, have limited sessions with counselors due to capacity issues. Again, I don't think there's a lot, in behavioral health where we can say we're going to reduce the frequency of services and think that the outcomes are going to be what we hope for. Those things just don't really pair. Mental health services being provided primarily remotely, including for those with higher needs and limited ability to engage with telehealth. So that's kind of a lasting dynamic from the pandemic, where everything immediately pivoted to telehealth. And there are some services that just don't work well, for telehealth. I can give you one example on the kids side, applied behavioral analysis, which is an intervention primarily for children that have a diagnosis on the autism spectrum disorder. Because of the in-home restrictions, that's being provided via telehealth, but that's the kind of service that really needs to be an in-person service to have the benefit. And so, and for adults, that if they're not connecting in with telehealth and that's the only offering, again, I think our concern is, again, it's just not going to have the effect that we'd hope to in terms of supporting them with the best journey to recovery and with the outcomes that they're looking for in treatment. On the outpatient side, all the levels of care are experiencing wait lists for services. Level D providers, so again, intensive in-home providers, are booking 2 months out. Residential providers, residential eating disorder, and partial hospitalization providers have wait lists of 2 to 4 months. And there are limited in-person services available, even with the community-based services. And we're trying to get better information about what capacity is there, because it changes. And actually in Care Oregon, we're standing up a referral team to really manage that even more specifically, because there's just a lot of triaging happening, where we're trying to understand wait lists and help folks get through wait lists in a way that's based on immediate needs. So I think moving forward, if we could go to the next slide. I can speak a little bit more to Metro, just the challenge of clients moving to different levels of care or to outpatient programs that are less intense from a more intense program. That's restricted. Some programs, intensive case management, community-based programs, have been closed to referrals for multiple months and don't know when they'll reopen. Additionally, assertive community treatment programs are closed to referrals, some of them due to staffing, others are full to capacity. Approximately, there's 30 to 40 individuals on wait lists for both of those programs and limited ability for in-person services. Medication services, because psychiatric time is so limited, those have really been prioritized for consumers with the greatest needs, often who are leaving higher levels of care. And that's not ideal for individuals that are receiving outpatient services that don't have the same level of access because the immediacy of need isn't at the same level. Again, ideally, that level of triaging wouldn't have to happen. Multiple appointments that are required sometimes before a client can get referred for med management and evaluation. That's, again, a triaging function. Access to prescriber-only services. So that would really be, if I was just interested in medication management and not interested in therapy or case management, those services are pretty difficult to get. If someone is saying the thing that works for me right now and the thing that I want is medication and not, 3 other services. So LMP appointments, that's either a psychiatrist or a psychiatric nurse practitioner. Those are 6 weeks out with difficulty getting bridging services for medications. And on the residential side, the state hospitals close to intakes, as we discussed. Inpatient programs are having difficulty discharging clients due to intake times and wait on the outpatient side. Some sub-residential providers have been closed or taking limited referrals. and staffing shortages in residential programs are leading to possible closing of more of these program types in kind of a domino effect. So moving on to the next one. So Jackson Care Connect is in Jackson County. Here are a few of the impacts there. Columbia Care, which is a major provider in Jackson County, was closed to intakes for a time, and their intensive case management program is over capacity relative to their current staffing. The county, with Jackson County, has eliminated their housing options that they previously had available to ACT clients. Relative to the SUD services, there are substantial wait lists for detox and residential treatment due to staffing limitations and the reduced capacity that we talked about before relative to COVID-19. Phoenix Counseling in Jackson County is serving fewer members inside outpatient due to staffing shortages. And On Track has been at risk of closing their men's SUD residential program. And then for other services, Family Solutions have closed their day treatment program for children. Options is 2 to 3 weeks out. And private practice network providers have limited access and are reporting that there's a large portion of that part of the network that's at capacity. So the last one, and I'll go through quickly and make sure that we have time for what's next and any other questions. Last slide is about my service region, which is Columbia Pacific on the North Coast. So Classic Behavioral Health, the ACT program was temporarily closed due to new intakes, and their Community Support Services program is not accepting new referrals. Tillamook Family Counseling had difficulty finding an ACT team lead. However, they have just hired for that position about a week ago. And Columbia Community Mental Health, their program is down 1 staff with ACT, and they're actively recruiting. Yeah, Margie.
I'm so sorry. I'm having problems with my technology today. But Tom, I hear all of this, and I guess I have concerns, and I'm hoping that there's a slide coming after this that shares what the CCOs are doing about this, what plan of action we have in place.
That's the next one, exactly.
Okay, great, thank you. And the wait list piece is still concerning for me when I think about how Medicaid works. So I'm a little confused about, is this impacting our funding, having these wait lists? Because I think there's some rule somewhere that doesn't allow for wait lists and Medicaid funding. So I could have it wrong. I'm concerned, I guess, more than anything. Thanks.
Yeah, you're absolutely right on both accounts. We're concerned too. I mean, it's a pretty grave situation, to be candid. And Medicaid does not allow for providers to maintain wait lists. That's generally not an acceptable practice. I think that we're at a time where it's kind of a little bit of a nothing else they can do when they literally don't have the staff to deliver the services. So they're kind of between a rock and a hard place in terms of having downstream funding impacts. I don't know that link has been drawn yet, but that's a really good call out and a good question. So I'm just going to kind of run through these last couple ones. So youth services have been impacted in Columbia County, as you can see there. And then crisis services, we were trying to open urgent walk-in clinic in Clatsop County, and that's been delayed due to staffing, but we're hoping it opens up at the end of August. So that's kind of really in the weeds for kind of the picture of concerns, and maybe we can go to the next slide.
Tom, before you dive into that, Sabrina has a question.
Yeah.
I was just, because I'm from a rural county, I'm from Klamath County actually, but this presentation, I'm assuming it's similar across the state in rural counties are non-existent, correct? Because some of this stuff I've never heard of before, so, and I just wanted to clarify that.
Similar in terms of the staffing dilemmas? I mean, I think it is similar. I mean, I can say I haven't specifically heard of the vacancies in Klamath, but in our service region in Columbia, there are a lot of vacancies. And, you know, I'm on a call every month with the behavioral health directors from around the state. And, you know, everyone is having the same conversation. How do we recruit peers? How do we recruit QMHAs? How do we recruit QMHPs, staff for residential programs? Where are people posting recruitments? Where can we find qualified applicants? And it feels like it is really a statewide situation that we're experiencing. I don't think there's any community that isn't really experiencing this shortage right now, just from the conversations that I'm hearing from other folks and CCOs around the state.
Thank you, Tom. Henry has a point. Henry, would you like to share?
Well, yeah, I just, you know, to the question that Sabrina had around, you know, rural counties being impacted. And I think the gentleman that's presenting has already identified this, that, you know, there's just oftentimes in rural or frontier counties, at least I can speak for Hood River and Wasco, having the experience of working in the emergency departments there and trying to find placements for folks, that we would often be, you know, there are no residential psychiatric facilities in those counties, so we would be transporting folks to the metro, to Unity or wherever, you know, and be placed, you know, if I had a patient in Providence and Hood River or in MCMC in the Dells, they would be placed on a list behind the folks that were already in the county, you know, in Multnomah County. So I think part of that's the issue, is that we just don't have enough facilities. We don't have enough beds for these folks, whether it's folks experiencing an acute mental health concern or a substance use disorder, specifically for youth. You know, and I know that some facilities have been closed, like Northwest Behavioral was closed several years ago because of their treatment of their patients. So oftentimes my concern is that when we have a shortage of facilities and resources, that can lead to poorer health outcomes for patients that are seeking services, because maybe those services are overwhelmed and then service quality is diminished. Thank you.
Thank you, Henry. Zeb, would you like to share? Oh, Zeb, you're muted.
Oh, hi.
Thanks.
Thanks.
Hi.
Yeah, thank you, Thomas, for this presentation. I can tell you, as an outpatient treatment provider, you know, we offer services from prevention to intensive outpatient services in a rural area. And all these things that you brought up are definitely a thing that affects us, you know, from the administrative burdens that you were talking about, all the way to, you know, posting job openings and taking a while to fill those positions. So yeah, definitely. I mean, the goal is, and you know, the Measure 110 grants is going to definitely help out with giving providers more resources to get more staff to support the need out there, because we can't be having wait list when people are really need help. You know what I'm saying? So
Agree.
I'm really glad to see the stuff that's being presented today.
Thank you, Zeb. Ron?
All right, thank you. And great presentation. Thank you again. One thing I haven't heard you identify is that there's a lack of funding for hiring. Is that correct?
You know, that's kind of where we're going next. And so I think that's a great segue in the last part. And that is some of what, you know, we're addressing with a funding that we put out last month. And I really appreciate the question, Ron. And I guess I just wanted to say to Henry, I agree. There's absolutely a ripple effect that flows back into rural and frontier counties. And Zeb, yeah, I know we don't want wait lists. And I think that's a big issue, because I think with wait lists, you know, I worry about, to be honest, and I'm being very candid, I worry about preventable death. And when there are wait lists, whether there's an overdose that's preventable or potentially suicide that's preventable, you know, that's something that those are very real risks for Oregonians. And, and we're in this work to make sure that those aren't the outcomes. And so I think, that's something that weighs heavy in my heart. And I think it's why the gravity of solving this problem as a state is so important now. So I think, what can we do? Providers, they're working upstream to maximize the use of peers and QMHAs and looking at how they can do that differently. Again, there's triaging of services based on acuity, some supplementing of services with telehealth. We're trying to take advantage of recruitment and retention, loan forgiveness. We've partnered with OHA because they've actually put together a behavioral health workforce loan repayment that's specifically carved out for behavioral health. And we recently had a presentation with that group with all of our providers who are all going to apply to work on a loan repayment pathway in addition to the HRSA rural loan repayment. Director Allen, it looks like you've got your hand raised.
Yeah, thanks. If I can get off mute. Yes, thank you for this presentation. And I didn't mean to interrupt what you were just talking about, because that's exactly where I wanted to get to. So, you're obviously not the only CCO in the state, but just, what initiatives are you folks taking? We don't, clearly the CCOs alone can't fix this, but OHA can't either. So we're looking for, what can we do in partnership? What are the CCOs already doing, and what more can we do together?
Thank you. Yeah, I appreciate that point. In terms of what we are doing, Kerrigan released $7.5 million in June between the 3 CCOs to support provider recruitment, retention, and to support workforce stabilization. And we're taking a couple other steps here. Supporting treatment pre-engagement really is about maximizing the contact and support with peers and traditional health workers. We think that is a really important strategy, especially as if someone's waiting for care, if they're pre-contemplative about treatment, making sure that we're making those connections with peers and traditional health workers. A little bit more about the workforce funding. Providers made plans and applied for the workforce funding, and that's going to support retention bonuses, recruitment bonuses, first month's rent, relocation expenses, hiring recruiters, basically recruiting firms. They're going to help us recruit to build the workforce, worker appreciation. There's just a whole bunch of creative things, baked in there. Frankly, a lot of it comes back to compensation, and a lot of it is in a different ways of forms of compensation. And so I think that's what we're seeing the providers use the funding for. We've made this initial investment, round 1, of $7.5 million. We're going to be looking at additional rounds of investment. And then the state, as was mentioned earlier, we're really excited about the House bill and that windfall investment that's going to be coming into the state. I think OHA has been a good partner in listening to different ways that we can relieve administrative burden and buy time back for providers to spend as much time as they can focused on client care. Reducing credentialing and other rules temporarily to increase the pace of building capacity and bringing programs into the state. We're also looking, as I think has been mentioned, the state level to start a media campaign to recruit into the field. I think one thing that I can't stress enough is that money alone won't solve the problem. Putting funding to it is critically important, and that has to be a part of it. But it's also just a factor of we need more people that want to work in this field, that feel connected to the mission of this work and want to do this work. We need to appreciate those that do this work and keep them well supported, and have all these dynamics happening at once. So obviously, as mentioned in the last presentation, more upstream connection to universities and really developing pipelines to bring individuals into the behavioral health workforce, especially from BIPOC communities, is really just a critical thing. In our rural counties, we can't just solve this by hoping we can recruit behavioral health staff from out of state and have them move to the North Coast. That isn't going to get it done. We need to build a workforce that has local roots and is connected in the community and wants to stay in that community, whether that's peer staff or staff that go for post-secondary education to be a therapist or a psychiatrist at all levels. We need to really grow and support the local workforce with a really long-term vision. And that's going to take time and resources. And so with that, I know I've taken a little more time than I intended with the set presentation, but I just wanted to leave it up to any more questions. And I see the question from Karen about housing. That one just popped up. That is absolutely an issue. The cost of housing, especially in the I-5 corridor, North Coast, there are times when we've been recruiting folks to work in Columbia Pacific in the region, and they can't find anywhere to live, like literally. And their applicants are lost because there just isn't affordable housing. So there's just a lot of dynamics that are complicated. And a lot of those dynamics have roots in structural inequality. And I think it's really important to bring that, as an issue that we're talking about too. So thanks. With that, I can take any questions in the time that we have left. And I'm not tracking the time, so please cut me off when it's time.
We are not shy about that, Tom. Thank you. But we do have Aowen has a hand up. Go ahead, Aowen.
Yeah, this is Aowen. I am a medical doctor and a prescriber of substance use treatment, medications for substance use. And I want to reflect a lot of what you're saying. I supervise a youth residential program where it's enormously challenging to find staff. And we received a bunch of youth from some of those closing programs. Just one other reflection, which I think was embedded in what you were talking about, but is ways to bring people back into the workforce, or those folks who may have credentials, may have the training, but have not used it. In the world of prescribing for substance use conditions, we have lots of prescribers who may have gone through the training in order to be able to prescribe medications, but they haven't used it. So it's another kind of retention / re-engagement strategy that I hope we can include. And of note, those prescribers are not only psychiatrists, they include medical doctors, MDs of any specialty, DOs, NPs, NPAs, all can prescribe medications for substance use conditions.
Thank you, Aowen. I really appreciate that comment.
We have a question or comment from Amy. Go ahead, Amy.
Hi. So as a CADC2, I really enjoyed your presentation because it's, excuse my Parents' Day. I really enjoyed your presentation because it really is true. There's like all this. I hear quite often the frustration of the clients or the clients that are waiting to get in to get these ASAMs done or get these mental health assessments done and get placed, or, and the shortage that we have of clinicians that are able to do that. And I think in my frustration is I just want to be able to help people and get these ASAMs done. But, unfortunately, the place I work at currently, they can't do the ASAMs there. So I have to refer them out. And then it's a constant cycle of the disconnect where there's that little gap in service that needs to be bridged. And I know that we have some changes coming to our county that's going to bridge that gap, because Community Counseling Solutions is taking over, and they're going to be able to do both the dual diagnosis stuff. And so it'll be good, but I tell you, it can be very frustrating because we want to help. I want to help. I want to, for instance, I had a client today needed to get an assessment done because he wants to go to treatment and he's ready, and no one can get him in for 3 weeks.
Yeah.
And it was like, and he was so disheartened, and he's clean right now, but he knows he needs treatment, and he has to have the ASAM to do it. And I'm like, man, I wish I could do it, but I can't, because there's a relationship issue there where it's family. But very frustrating, very, very. But I appreciate your presentation.
That's a powerful story, Amy. And the thing I think about that gap that you mentioned is when someone's ready to walk through those doors and get support, and they can't get it, are they going to walk through those doors 3 weeks from now or 6 weeks from now? And so that's why, working together across the state and between the CCOs and with the ideas of everyone here, we want to address those wait times so that when someone's ready to say yes to care on their journey, the care is there.
Thank you.
To that, you need it.
Henry, would you like to share your point from the chat?
I'm okay, thank you.
All right. Go
Yeah,
ahead.
Henry, I did see your point. And I think, I had some director of a behavioral health organization reflect that back to me a couple of days ago, where there's an equal amount of work that needs to be done to support organizational cultures that are truly inclusive and to address exactly what you mentioned. And it isn't as simple as just recruiting without doing the other parts of that work. So I appreciate the complexity that you represent there.
Yeah, and I guess my point is more of like on a, just a larger scale in the community. Like if for example, I have a friend of mine that wasn't willing to move out of Metro because, they're Korean and they don't want to be in a place where there's, so many white people and no Korean grocery stores, so it's like, for some people it can be really kind of almost, I don't know, like I have a friend from Brooklyn that's like, where are all the black people in Oregon? Like it can be really hard to be a person of color in a community that's primarily, monocultural, and try to feel like you can, whether you're like my Sikh neighbors next door that like are the only people that have a turban, in my neighborhood, or like if you're Jewish and there's no Jewish temple to worship at, it's like there's just, I think for a lot of people it can be difficult to be in a community where they don't see themselves being reflected. Thank you.
Appreciate that comment. Thank you.
Thank you, Henry. Any other questions or comments for Tom? All right. Thank you very much for your time and energy and sharing with the council today.
Yeah, thank you all for inviting me. Thank you for the work that you're doing. And, I think it's going to take all of us together, all of our efforts, all of our ideas, and a lot of new resources. And I know I presented a lot of pretty bleak information, but I've got to say, I believe in the resiliency and capacity of Oregonians, of folks in all of our counties, and the capacity for us to make it to the other side of the workforce crisis. And I think there's going to be some new resources brought to bear that have never been in the behavioral health system before. So I know some of it feels pretty overwhelming, but I'm buying optimism today. And so I hope that, some of what you take away is just how much we need your input and energy and ideas to be a part of solving this.
All right. Thank you very much, Tom. Sabrina, I'll turn it back to you.
Okay, thank you, Roberta, and thank you to the presenters today for being here. As we are here to talk about the direction of the council and the vision that we have for Burns, and so I'm going to present a couple of questions and then we're going to leave it up for discussion. A couple of the questions that I have written down, there's 3 questions regarding the Burns and the services that they provide. One of my questions would, who would a burn provide services to? Who would they not provide services to, and why? And what organizations would the burn providers not work with or take referrals from? And I was hoping that we could leave that open to discussion for the council members, and if they need me to repeat my questions, I will. Thank you.
Can you post those questions in the chat, Sabrina?
Yes.
Thank you.
All right, while Sabrina's doing that, so this opens up the discussion about burns and your vision and values around burns as a group. And so that's what we're trying to dig into today. We started this conversation, I want to say a couple months ago, and we came up against maybe some obstacles in the conversation. One of them was the workforce issue. So you heard about the workforce crisis and really getting folks on the same page about what that looks like throughout the state. So now that we've had substantive presentations since that initial burn conversation, we're thinking that you all have a little more meat on the bones to dig in. So Sabrina's questions, who will the burns work with? Who will the burns not work with, and why? So we can start there if folks have any thoughts about that to begin. Dharma, please.
I think for me, it's really critical that the burns work with everybody regardless of insurance coverage type or lack of insurance. I think that's something that feels like a really important policy value for me in regards to who would have access, is just ensuring that it's not tied to like CCO region, and it's not tied to having insurance coverage necessarily. I know that some of the burn service providers will be accepting various levels of insurance, but we should ensure that burns are able to provide services to clients regardless of their insurance coverage.
Thank you, Dharma. And just to be clear, Wes and OHA staff are capturing your thoughts and comments as a group today for that beautiful grid that he shared, and you'll see again. All right, Eowyn, go ahead.
Yeah, I'm intrigued by this question because my first reaction is, well, everybody, of course. And so it's hard for me to imagine who we wouldn't work with. I think folks living in Oregon might be a boundary that we would set because we're going to be focusing on services in Oregon. But then what about folks right across the Idaho border or in Vancouver, Washington, for example? But I think there should be a geographic definition because that's where the services are going to be, and we are funded by state dollars. But other than that, I 100% agree it should be regardless of insurance, and I would be wary of setting any other guardrails, but I'm curious to hear what others here think because I'm having trouble imagining what those would be.
Thank you, Eowyn. Karen, go ahead.
Eowyn brings up a good point. I can imagine kind of like the DUI system. There are people who drive over from other states, Washington especially, California and Idaho, who may get a ticket. They may get a citation here in Oregon, and then that's a good question. Like what do the burns do with them if they're going to go back and live in Idaho or Washington or California or another state? They could be here from any other state. But as the DUI system, people do have to comply with Oregon's laws. If they get a DUI in Oregon, they've got to go see an evaluation specialist, and they can do treatment in the other state that they're in. But of course, this is not going to be anything like the DUI system. I'm just using that as a comparison. But I think that is a good point to consider.
Thank you, Karen. Sabrina?
Yeah, I would just like to voice my opinion. I believe that everybody that's a recipient of the Measure 110 funding, that they should be open to take referrals and work with anybody, because why not? And I don't think that they should be exclusionary to other organizations, because then we're creating the same lateral oppression and the same systematic problems that we've had before. And that can somehow be a trickle effect to the people that we're serving and cause like this unneeded like feeling that might trickle, like I said, onto the people that we serve. So I think it should be open to every organization, that they should work with each other. I don't think that there should be a reason why one organization should tell another that they're not willing to take referral sources from them. And that definitely it needs to be warm handoffs.
Thank you, Sabrina. Folks agreeing with you. Morgan, would you like to say more?
no, that was just my initial thought too, was, well, wait, what is this question? Because why would we, restrict or gatekeep if we don't have, if someone, you walk into a DHS office, they can send you over there. I don't know. I cannot conceive of a scenario where we would need to restrict that. One might arise in the future, some like way out there thing, but the more referrals, the better. And that point that Sabrina just made about warm handoffs, that's also very critical.
Thank you. Ron, you have a really interesting statistic in the chat. Will you share with the group, please? You're muted, Ron.
I was trying to find
Thank
where the
you.
button was, but yeah, I was just looking at the most recent data that we got from the Judicial Department or Department of Justice on citations, and that's the number that comes from them. Of 1,085 citations that have been issued, 81 were from folks out of state. So it's a very small number.
Thank you. Dharma?
I'm just a little concerned about how we would define Oregon resident. So beyond like the people who are in like, close to state borders, but I primarily work with students, right? And so many students who are living in Oregon are not Oregon residents, or I even work with international students with substance use disorders who may need access to Burns services, but may not be Oregon residents. And so I don't really have an answer about this, but I think it's just a consideration that especially with young adults who might be here for school or migratory workers, we want to ensure that they have access to care too. I'm also thinking that we shouldn't have limitations based on citizenship status, especially understanding that disparities to care impact undocumented folks so severely that we should really consider expanding access to burn services to individuals who are undocumented.
Thank you, Dharma. Eowyn?
Sorry, managing all my buttons at once. I just want to affirm what Henry said, absolutely regardless of status. And I'm sorry, what Dharma said. And then also, people who live in Oregon, I think, should be eligible rather than us having a specific criteria for what would count as a resident.
Thank you. Keisha raises a point in the chat, but I won't call on Keisha. I'll just read it. Are the burns just going to be another source that is overburdened with lack of connection to services? Go ahead, Sabrina.
I was just going to say, I would hope not. I mean, I'm hoping that with all the funding and stuff, that's what we're going to recreate. And that was the point of my question, because I feel like with people with so much funding, there's no reason to say no, that we cannot work with each other. And I don't foresee any reason why one organization should tell another organization, we're not going to work with you and or we're not going to take a referral from you, because there's going to be such an abundance. And we got to get out of the old frame thinking of scarcity, that we should be able to service everybody if we are able to implement this correctly.
All right, that's a thread we'll hold on to, that abundance versus scarcity thread. Karen, go ahead.
I think Sabrina said a lot of what I was going to say, but I think this gets more into our conceptual vision for this versus the questions that Sabrina asked. But I would hope that applications, if you will, for the burn, that we make sure that they have existing or they have developed partnerships and made it official, however we want to do that, by saying we want you to have memorandums of agreement and that everybody has signed that, and you've got this network in place, before they're established. So that's my comment. But I think Sabrina said it well.
Thank you. Dharma?
I'm just curious if CCOs or QHMPs are part of a burn, will their financial obligations like change, right? Like who they're able to treat, will that change based on receiving burn funding, or will like yeah, I guess I'm just wondering, or maybe something that we might be thinking about too, is that if they have constraints in what kinds of insurance they take already, will receiving burns funding expand what types of insurance these places are able to take? Or would they be able to kind of spread the services across the burn if not all service providers in a burn can take all insurance?
Is that a question an OHA staff person can help with? Go ahead, Steve.
Yeah, I think that the really powerful piece of the funding that over which this body has authority are marijuana funds, and I'm thinking, I guess, of Willy Wonka on the golden ticket. Like, we can use those funding, that funding in really creative ways that reduces the level of requirements, et cetera, to use it. So, you know, if a person doesn't have access to OHP or private insurance, if they have no other way to pay, we actually, as I understand the legislation, have an obligation to support services for those individuals using these marijuana dollars. And then, you know, to the prior point, I mean, there's enough funding here, it's over $300 million, that I think scarcity, you know, is, you know, obviously there's always a limit to everything, but we're no longer in a period of scarcity. We have enough abundance that we can do some things that we weren't prior able to do, which is, I think, extraordinary. Did I answer your question?
Yeah, I think so. I'm also just maybe concerned about like how like some like Benton County Health Department, for instance, in order to get services there, you'll often need referrals from a county health provider, right? So I'm just worried that if those kinds of agencies end up taking on burn funds, that they won't actually be able to take the appropriate referrals from maybe a different burn service provider who they weren't referred to from that organization, if that makes sense.
Yeah, at the risk, thank you, Dharma, at the risk of sort of getting deeper than we maybe want to get today with the time we have, part of the referrals in the medical system as it is now relate to, you know, what's sometimes called, you know, is the service medically necessary? And that term is important because, for instance, a CCO or other funder of services doesn't want people to get care that they don't need, and doesn't frankly want to pay for care that people aren't deemed needing. We don't have the same restrictions here. As we write our rules and term and services, clearly, you know, we don't want resources, you know, to go where they're not most needed, but we have more flexibility to design that. Now, I think maybe to your point, Dharma, if we are working with an organization that's used to working along those parameters of, you know, having a screening assessment and medical determination, you know, their clinic practices, you know, are such that, you know, maybe that would be their tendency anyways. But again, I think these marijuana dollars are incredibly flexible, and I think we get to do some unique things with them that for the purpose of lowering the bar on access to services. So I'm not sure if I did any better, Dharma. You have to tell me if
Dharma gave you a thumbs
if I'm
up.
answering your question or not.
You got a thumbs up, Steve. Zeb, would you like to share your comment before we go to AON?
No, I was just saying that, I mean, we're about trying to get people help, and insurance should not stop anyone from getting help. Anybody receiving Measure 110 funds should be seeing everybody that comes through that door.
Thank you for sharing that. AON?
I lowered my hand.
Okay. All right, Sabrina's questions. Let's see. I got a little sun glare going on here.
I think, Roberta, just from my point of view, I think majority of my questions were answered, which we shouldn't be limited. We shouldn't be limiting who receives. We shouldn't be limiting where the referral source comes from, and that we should work with everybody that walks through the door, because why not? That's the point of the measure, is to give people low barrier services. And if we start creating all these different red tapes, then we're just going back pre-measure 110, I would think, and that was my consensus, Roberta, just to let you know.
Awesome, thank you. We talked through in the prep meeting about some other potential questions. Wes, do you have those questions to share with the group? And if not, that's okay. I have them in front of me.
I do.
Okay,
I'm
cool.
sorry.
Thank you, that's all right. All right, I'll read them if folks are on phones or have a hard time reading. What is the council's vision for the burns? What is the impact you want to make with these new systems and investments? How is that vision impacted by workforce challenges that you heard about today? What can the burns do to add capacity? So any and all of those you'd like to address, whoever has the first one will take us in the direction that we're going to go. Karen, go ahead.
One vision that I would have is that people don't have to go to an office. They don't have to call and make an appointment to go into an office. So people are met where they are, whether that is downtown, on the railroad tracks, or somewhere else. It's more of a engagement workforce and they're doing outreach and engagement, and there's not somebody, just saying, well, we can get you in next week. That's not, that would not be the vision that I would have for this. Thank you.
Would anyone else like to speak to Karen's point? Supporting or otherwise? Meeting folks where they're at? Sabrina?
Yes, I definitely think of going out to where they're at, because like I heard on a presentation before, like from up into the metro area, I think it was from Carlos, where he said they're not always willing to come to the office. And so going out to meet them, like wherever they stay, or meeting them halfway to where they're at, is what's beneficial to them, and not what we think looks like the right idea, what's actually benefiting to the people that we're serving.
And Karen, there's a clarifying question from Henry. Does that mean an ACT model?
Well, it is. I mean, one thing I do like about ACT is that it really provides a lot of wraparound services for people, and it's meant to be a high engagement, but wraparound is for people with serious and persistent mental illnesses. Now, if somebody does need that kind of service who has a SUD condition, yeah. But even if, I'm just talking about anybody before they even have any kind of clinical assessment or clinical this or that, there's people out there engaging with people, talking with people that are on the street or in some, wherever they are, wherever they happen to be. That's what I'm talking about.
Great, you're seeing some agreement. Dharma, do you have something to that point? And then we'll get to Eowyn.
Just in regards to meeting people where they're at, I think telehealth options are going to be really critical to kind of help to facilitate at least screenings and things for folks that are disabled, folks that are geographically isolated, or considering that, especially for immunocompromised communities here, they haven't been able to get vaccinated. They might have less options with going to in-person care, at least for a while.
Thank you. Eowyn?
I agree with all that's been said. I think for me, it's low barrier, which we've talked about. So people have easy access into the system. Comprehensive, meaning there's a wide range of options available across the spectrum of treatment options. Culturally specific, culture meaning many different things, and offering specific options to people. And then really harm reduction focused, so identifying people's goals and working with them to meet them. And I think a critical role of the burns is going to be identifying gaps in specific service areas. So where there aren't culturally specific services where they may be needed, where there's not very much youth residential. We know that that's true across the state. And what are the opportunities to access those services, perhaps in other parts of the state, or build new programs? So I think the burns are going to be essential in identifying those gaps, and they may not be filling those gaps, but they may be helping to identify what are the key service gaps.
Thank you, Eowyn. Blue?
I cannot remember offhand how we are defining harm reduction at this point, but I think maybe calling out that one of the things that harm reduction can include is outreach, where folks can go and meet people in the community. I know PPOP talks about the outreach that they do, and I'm able to do outreach in Benton County as well, but I know that some organizations just don't have the capacity or the funding to be able to actually go into the communities, and I think that would definitely be an important thing that we should probably call out as one of the components.
Thank you, Blue. Any more on that harm reduction vision? Sabrina?
I think, I don't know if this has been said or redundant, but I think with outreach, not only should they have outreach with the people going out in the field, but with supplies that will benefit the people that they're out there serving. That can be beneficial to them, water, socks, backpacks, whatever that looks like, some kind of something to help them get through to wherever they're going.
Great, I see Blue's approval to that one. Wes, and then Henry. Go ahead, Wes.
I had a question about harm reduction, if I could ask the group. This has come up over the past couple of days about the use of drug testing as a gatekeeper to other services, whether that be housing services or something like that, but paying for those drug tests for folks in recovery so they can get access to services, or it could be as a result of the child welfare system allowing them to remain with their children, things like that. That's an unfunded service for some people and could be part of the scope of harm reduction. So I wanted to ask about that to the council, if that falls within the philosophy.
Blue?
It sounds like that is more maybe on the spectrum of recovery, only because from my perspective, and I could be misunderstanding the way it's being described, but harm reduction is reducing drug-related harm, and I'm not seeing like how drug-related harm directly ties to paying for somebody to get their drug test done. But with that being said, I think that it would be something that should possibly fall under Measure 110, maybe not as a harm reduction measure, but as a recovery support. I didn't realize that people had to pay like out of pocket for drug tests if they were required. So that's new information for me.
Thank you, Blue. Henry?
Yeah, I was just kind of like brainstorming off of what Karen was talking about. And I think having like a prior model to some of this stuff can be helpful for me to kind of conceptualize of the service. And so, I was thinking of like the CAHOOTS program in Eugene that's, but without the law enforcement component, if we had like, and then if we're talking about minimum requirements, like, a CADC and whatever the other two are supposed to be cruising around in a van together, like Scooby-Doo or whatever, just like going around and giving out Narcan and like, maybe that could be part of it. I don't know. Just maybe I need more caffeine. I don't know. Thanks.
Thank you, Henry. Karen in the chat just wrote Narcan. So Karen, do you want to speak to that a little bit as it pertains to Henry's vision?
Yeah, when I think it was Sabrina, or I don't know, somebody was talking about making sure they were equipped with supplies and things. And yeah, Narcan, I mean, that would just be one example. But I think these folks that do this outreach, we don't really have a lot of people that do this in the state. So we are talking about a big vision here. I would think they need to have CPR, first aid training. I mean, they're going to be kind of like first responders. And I'd like to be alive and in this career long enough that one day people are just as proud to do this as they are to be a firefighter or a police officer, or a nurse. There's been different professions that have overcome stigma, and we need to be the next one, the behavioral health workforce, because we are on the front lines. Thanks.
That's inspirational. Thank you, Karen. Wes, do you still have your hand up from before, or is this new?
I apologize, taking notes and I.
Okay, no, I can do it for you. I just didn't want to miss you. All right, go ahead, Ron, and then Dharma.
Yeah, I just wanted to mention a couple things. One was that the only place I've heard of drug testing mentioned in the harm reduction space as being able, is organizations were interested in purchasing, I believe it's called a mass spectrometer. And a mass spectrometer is basically tests for impurities and abnormalities. I'm not sure abnormalities is the right word, but it's a way of checking someone's supply to make sure that there's nothing dangerous or harmful or lethal. If I have that, you can check me on that, Blue. Right.
I would just say, I just call it drug checking if they're checking the drugs versus drug testing, but they do sound very similar.
Yeah, so that would be the only space, that's the only phrase I've heard in the harm reduction space that made sense to me. And just in general, just generally for the folks who are involved with the evaluating of the grant applications, we saw a number of outreach applications for folks who wanted a vehicle, who wanted red boxes, they wanted supplies, they wanted to be able to get out into the rural areas and be able to do, take supplies and do outreach. And so we're already seeing that in rural communities and around the state, and it's something that I fully support.
Thank you, Ron. Dharma?
This is just an aside, but I think that for me, thinking about adolescent and youth services, especially with the built-in protective factors that are built in with it, I think that educational recovery and harm reduction services are going to be really critical. And just understanding that without explicit reference, these organizations are often unable to access funding. So without explicit reference to the funding of collegiate recovery or collegiate harm reduction, as well as like recovery high school programs like Harmony Academy up in Portland, they're often unable to access these kinds of funds. And so I think that for me, that vision should include educational recovery and harm reduction supports explicitly in language, just so we can ensure that they're in there, especially because these kinds of services include things like professional development, often include things like housing at collegiate recovery programs. And I think as far as our youth and adolescent interventions, it can be a really critical kind of site that we can consider that's been left out of normative funding cycles.
Thank you, Dharma. Ron, did you have something else?
Sorry, I didn't take my hand down last time.
That's all right. Yeah. I always err on the side of leaving it up in case I missed something. Wes, do you mind putting that list back up? We have about 8 minutes left in our time together this week.
And we're probably going to pick this up at the beginning of the next meeting. Yeah. So.
Sounds good. Sounds good. So yeah, so maybe marinate between now and next week on it. This list can be shared with you all via email, so you can be thinking about these questions as well. Tri-chairs, do you want to pose another one of these questions, or do you want to, how do you want to take it from here? Sabrina, I'll hand it to you.
I don't know. I was kind of thinking about one more question in I was leaning towards what is the impact you want to make with these new systems and investments?
It's a big question.
We'll call it a tickler for next week.
Yeah,
who wants to start up? Yeah, tee it up. Ron, why don't you tee it up?
No, I'm good with it's a big thing, and I want to hear what other people will have to say before I really weigh in. So.
All right, who wants to take it on? Not have all the answers to all of the questions definitively, but who has any thoughts about what kind of impact you want to make with these new investments? That's a beautiful thing to think about. Karen?
This might sound flippant, but I want to not be number 50 in the Mental Health America report. But actually, in all seriousness, the more we identify people and get the prevalence. You know, we understand more about prevalence as we identify people and collect data. So that actually ends up making us look worse in the Mental Health America report. But that aside, the vision is I don't want anybody at all in the state of Oregon to wonder, how can I get help if I have a substance use condition? You know, I'd rather have everyone know, you know what, I can get a hold of a burn, or you know what, someone's going to walk down the street any minute and they're going to engage with me and talk to me. That would be my vision.
Thank you, Karen. Caroline?
Yes, I was just meeting with my tribal council yesterday, and I'm telling them change is coming. And so to me, when I was talking to them, is that anyone at any time should be able to have access, and it needs to be immediate. And the climate needs to change in terms of how we're looking at low barrier and harm reduction. And I want to make sure that we find some way of working with our different human resource, because there's zero tolerance for those who are employees. And after listening to everyone's story over the last 2-3 months, we have to rethink what that means. We put a lot of effort into our employees. We have a lot of qualified employees. They take a drug test and they're out the door. And so I'm just telling my tribal council that things have to change, and things are going to change. And this is the mechanism, I think, the beginning to make sure, again, that everyone has access and that it's immediate and that we change how we do business.
Thank you, Caroline. Wes, do you have a follow-up before we get to Blue?
Oh, I defer to Blue.
So I was just thinking about, you know, I would like to see a reduction or ideally an elimination in the marginalization of people who use drugs, and also people of color, transgender and queer communities, you know, just really like hoping that we can bring folks in from the margins and create more inclusive systems.
Blue, I'm seeing hearts and thumbs up for your comment. Anyone else want to speak to that? Dharma, go ahead, please.
Yeah, just to that end, I think that at least I really value abolition as kind of a really central tenet to what we're doing here, especially because the voters voted to kind of move us from the criminal justice system, or the criminal punishment system rather, towards a health system. And so I think that for me, this, you know, that the vision really sits with abolition as you know, a removal of punitive measures, and abolition not only in just like the removal of the criminalization and of small amounts of drugs, but the removal of kind of criminalizing elements or kinds of punitive elements in our provisions for care.
Thank you, Dharma. Blue, thumbs up on that. Dharma used the word abolition. I think that's probably a good place to stop and marinate over the next week. We can share these questions with you between now and then. Amy, I do see your hand up. Do you want to make a comment before we take off? Oh, can't hear you.
I just want to say real quick that that person that I was talking about that had put on the waiting list just had a seizure in my front yard and is on his way to the hospital. We need to do something to make this a smoother transition for people. That's all.
Amy, thanks for sharing that. Definitely make the work real and pressing and feel the urgency. All right. Tri-chairs, I'll turn it over to Sabrina. Ron, do you have anything to close out before I take it to Sabrina?
No, I think it's been a wonderful conversation, great presentation, good, strong, robust discussion. I think we're headed in a really fantastic direction, and my thoughts and prayers go out to Amy and her family members, and it's just an example of why we need to be in the space and closing those gaps and making services available immediately for people. Whether it's emergency, it's a peer with an emergency housing, with immediate support, those are things that we can do. So,
Can I just say,
go ahead, Karen.
This is real time here. So let me just say, CCOs are responsible for care management. And what I'm going to do now is call our care management team. Since this person resides in our region, I've been chatting with Amy during this thing offline here, just to try to see if I can get some help for this person. So just know that we're going to take action on this, and this is real time and a very interesting scenario. So thank you.
Thanks,
thank
Karen.
you. Thank you, Karen.
Sabrina.
Yes, I would just like to thank everybody from the council for being here today, and I'm glad that I got my questions addressed and to know that we're all what our vision and our direction is. And so as we go on this coming week, we can think about the questions that Wes presented and what our vision and the direction is for the people that are being served by the burns, for such importance as what is going on in Amy's life as well as all across the state of Oregon. So I appreciate you guys. Thank you.
Well said. Thank you, Sabrina. Take care,
Thanks,
everybody.
everybody.